and the network has been waiting for it, and it is coming network. Big rest assured. Thank you, Dr. Siwiinga. Network, we are starting now with our session for today. As I earlier mentioned, we are talking about antimicrobial resistance and advanced HIV disease. So our presenter for today is Dr. Chitalu Chanda, as earlier introduced, and we have the panel of experts going to help us to have this delivered with fidelity. Dr. Keneth Kapolowe, Dr. Matibula are experts in the area and with huge experience. Under the leadership of Professor Lloyd Mulenga, we are having this session on the panel of experts. So network, let me now introduce Dr. Chitalu. Dr. Chitalu, you are welcome on the call, and please kindly go ahead.
Thank you so much, and good afternoon, everyone. Am I clear?
Yes, Doc, you are.
All right. I think I've seen Dr. Kapolowe has joined us, so thank you and welcome, Doc. Can share this. Is it okay if I can share from my end?
Yes, Doc, you can do it from your end.
All right. So, and Happy New Year to everyone, and good to see some old faces, and welcome to today's session. So today we are going to just look at antimicrobial resistance and advanced HIV disease. I have no conflict to declare or disclose. So we have 3 objectives for today's session. That is, we are going to look at really the burden of advanced HIV disease and the AMR. And then we'll dive a little bit just to look at what are the common pathogens, and probably this is what helps you to empirically decide on how you're going to treat. So the common pathogens that then are MDR or multi-drug resistant, that are commonly isolated in advanced HIV disease. And then we'll just then scratch on to discuss the management of antimicrobial resistance in advanced HIV disease. So I wanted to understand the audience, and I have just some 3 pause over.
Thank you, Dr. Chitalu. Just for us to understand network, how many patients with AHD do you see in a year? Just an approximate. Is it that you've never seen a client with advanced HIV? Is it B, 1 to 10, or it is above 10? So you can just try to put your response in the chat so that we have a view of what is pertaining on the ground. Okay. So, Dr. Chitalu, we have average from B to C. So we have colleagues who have seen clients in between 1 to 10, but the majority, based on what is being given in the charts, is actually above 10. Okay. So So just to check on ourselves, this is another a question. How many of patients with antimicrobial resistance have you seen? Is it 0? Is it B, 1 to 10, or above 10? just in the chat. Okay. So, Dr. Chanda, here we have some mixture in the responses, and what is coming up is that we have some colleagues where they have not seen a client with antimicrobial resistance. So this opportunity of today will really help on where we are having A to get an improvement as we move. So we can move to the next one. Okay. So now, as a facility, do you do cultures? It is either A, yes, B, no, C, yes, but I have never seen a result. D, I have no idea. So what is the real situation at your facility? Okay. Do you do cultures at your facility? Is it A? Is it B? Is it C? Yes, you do, but you've never received a result. Is it D? I have no idea. Wow. So, Dr. Chanda here again, we have some responses coming as D. Okay, and we have as well C coming out. Okay, so this also will help us be guided on today's session. We can go to the next one. Great. So this is our poll question number 1. Which one is correct regarding antimicrobial resistance? Is it A, failure to antibiotics to function? Is it B, unresponsiveness of the organs to antimicrobials? Okay, so network, you are quite active, and we have seen some responses quite interesting, Dr. Chitalu, what we are seeing on the responses. So network, we have 5 seconds to go, and we should close the poll. Okay, so which one is correct regarding antimicrobial resistance? Is it A, failure to antibiotics to function? Is it B, unresponsiveness of the organism to antimicrobial? Which one is the correct answer? Okay, so we are ending the poll here. So this is the response from the network. 86% believe that B is the correct answer. Okay, so network, we are going to move to the next question. Dr. Chitalu?
Thank you so much, Dr. Mongomba. I think the next point is further down. And thank you for the response. I think that it gives us an understanding that probably a lot of us are attending the AMS eco sessions, because the 86 is like almost everyone, got to understand to say that they chose B, and then less than 11% chose A. So maybe we start with defining the terms that will help us address the 3 objectives that we set out to achieve today. So when we talk about antimicrobials, we need to understand then what is a microbe. A microbe is basically a microorganism, usually not visible to the naked eye, means that might require you to use advanced methods of being able to see it. And that's where microscopy comes in, either using electron or just a conventional microscope. So the microbes then can be classified as either fungal, bacteria, viruses, parasites. you know, so all these different classes then can be classified as microbes. And when we say antimicrobials, then we are talking about the different drugs that are developed to either reduce the growth or result in death of these antimicrobial or these microbes. Therefore, the different classes of antimicrobials can therefore be antibiotics, antifungals, antiviruses, or antiparasitics. So again, when we think about it, in line with our terms today, it means that you could then have a mouth drug resistant virus, you can have a mouth drug resistant fungi, you can have a mouth drug resistant virus, and you can have a parasite that is mouth drug resistant. And when we talk about microbial resistance, we're basically looking at development of resistance by a microbe to enable it to survive when exposed to antimicrobials. So this is where sometimes it would intrinsically be able to survive, or sometimes it develops the resistance patterns. So even if you give this microbe an antimicrobial, like you give an antifungal, the response that you expect will not be there. So the antimicrobials will fail to work against. Against this microbe. And you find that the same antimicrobial will work
Dr. Chitalu, you are breaking. We are having issues to get you. Dr. Chanda? Dr. Chanda, are you able to get us?
Resistance can be developed intrinsically or not.
Dr. Chanda? Dr. Chanda, we have challenges to get you. Are you able to get us? Okay, so network, it seems that Dr. Chanda is having challenges to really connect to us. As he's trying to join back to the call, please take note that we are talking today about antimicrobial and advanced HIV. Dr. Chanda was just giving a definition what antimicrobial resistance is. And he has mentioned of be it a virus, a bacteria, a parasite, a fungal, which go into a cell and resist to any antimicrobial given, and that is a resistance he's talking about. So let's take note of that. Then secondly, for those who joined a little bit late, please kindly take note of the session which was to be held last week in regard of the future of HIV program in Zambia regarding the stop order work which was instructed from the 24th January. So guidance was given, and we shall summarize at the end of the presentation. Dr. Chitalu, welcome back. We had difficulties to get you. Over to you. Dr. Chitalu?
Okay, thank you. I think I've been able to unmute. And then we also, I'm not sure where I dropped off, but I'll just say that then we have advanced HIV disease. I think most of us are aware of what this is. And this is where now you have either a patient who is a person living with HIV who is less than 5 years old, or they have a CD4 less than 200, or they have a double clinical staging 3 and 4. And we do understand that it's very key for us. When we think about advanced HIV disease, it's a
Dr. Chanda again, we can't get you. So network, apologies on the network, which is having some issues. Dr. Chanda, you are welcome. We are able to see your screen.
Thanks. Let's hope the network holds up. So these are the few terms that we need to remember, like what advanced HIV disease is. Basically, it's now a person living with HIV who has a low CD4 less than 200, or somebody who's got an age of less than 5, and somebody who's got WHO clinical staging of 3 and 4. And this is very key for us because it determines the outcome of our patients in terms of morbidity and mortality. So we need to understand the epidemiology of advanced HIV disease in Zambia. And most of us, from our responses, we say that we at least see 10 patients with advanced HIV disease per year. And that should make us think to say, then even if we're turning epidemic control, we are still seeing patients with advanced HIV disease. However, 50% of patients who are HIV naive or on treatment tend to have advanced HIV disease, especially at time of either returning in care or at time of diagnosis. So they might have either a low CD4 or they might have co-infections with either TB or crypto or any of these other WHO staging 3 and 4. But over the years, really the trend in terms of advanced HIV disease has declined with time. And this could be because of maybe rapid initiation of ART, and we're not waiting for the CD4 to drop, and that could have an impact. But it could also be because of strategies to active finding of TB cases. Now, some patients who are treatment experienced, especially in Africa, like South Africa, advanced HIV disease still is reported to be around 50%. And this could be because of using just a CD4 as a marker. We find some patients might have started with very low CD4 and that fails to recover as well. So basically, it swings around 40 to 50% of our patients presenting with advanced HIV disease, whether they're just retaining care or at newly onset of diagnosis, or they have been in treatment for quite a while. But what is also interesting is that if you're going to look at then the patients that you see in your inpatient section, you will find that majority of them, 66% of them, will be found to have advanced HIV disease compared to those ambulatory patients that are stable that you're going to see in an outpatient setting. And this is very key because now the setting you're seeing these patients mostly in can then predispose them to developing antimicrobial resistance. So look at the interaction that most of our patients with advanced HIV disease are more likely to be seen inpatient compared to being in an ambulatory setting. And then that predisposes them to having advanced HIV disease. In some countries in Africa, you will find that the younger populations tend to present more with advanced HIV disease. Maybe it could be the increased prevalence, but we also see that a good proportion of those that are between 15 to 25 are also presenting with increased cases of advanced HIV disease. So look out for where these patients are more likely to be, and that can predispose them to developing AMR or being infected with organisms that are mild drug resistant. Then when we think about antimicrobial resistance, basically if you look at WHO reporting, really over 76 countries in the world have reported antimicrobial resistance. It could be resistance to one drug, it could be resistance to several drugs, but the number is quite significant. And most of us in our setting tend to use drugs like cephalosporins. Most of the, we use penicillins, cephalosporins commonly. And we find that most of those countries that have reported, including Zambia, we tend to see that a lot of the isolates like E. coli tend to be resistant to cephalosporins like cefotaxime and ceftriaxone from that class. If you think about Staph aureus, 35% of the isolates tend to be methicillin resistant Staph aureus. And this could be acquired from an inpatient or this could be acquired from the community. I think it should alarm us to say when you actually think about urine isolates, you will find that then most of these are quite resistant. Most of the isolates are E. coli and they are quite resistant to the cephalosporins that commonly use. It's interesting when we come and talk about management, then how is it that we're observing this high number of cephalosporins and yet we're still using these same antibiotics and some of our patients might actually be doing well. If you think about MRSA, when you compare those who are HIV positive to those who are HIV negative, you're going to find that those who are HIV positive tend to be colonized. So where is the colonization likely to occur? Sometimes it will be in the nostrils, sometimes it will be on the skin. So a good proportion of those that are HIV positive are colonized with MRSA, which is Staph aureus, compared to those that are HIV negative. And we think about the same organism in terms of being a cause of an infection. You find those who are HIV positive are more likely to have this organism. So 49% versus 39 if you compare to somebody who is HIV negative. So you see that firstly, there is increased resistance, there is increased colonization of these organisms, that especially in people who are living with HIV, and more in those who have advanced HIV disease. If we think about other organisms like CLEP, again, resistance is significantly reported to be more, and we're seeing an increase in terms of resistance to even carbapenems. And this could be because of increased use of the carbapenems. Okay. If you come to fungal, there is a rise in terms of the number of cases of reports of Candida auris being reported around the world. And this has significance because it's quite a resistant organism. So when you think about somebody who's got low CD4s, the risk of having really asymptomatic colonization of other organisms like Enterococcus is way high, 300 times more than somebody who's got a much higher CD4. So we need to think around to say, one, advanced HIV disease puts someone already at risk of a poor outcome. But then further on, we think about them having an increased risk of having an organism colonizing either their gut, their skin, and this organism can cause an infection. And you can see that the risk of colonization and the occurrence of colonization is around 8% if you think about Enterococcus. And the same organism, Enterococcus, if you look at how common resistance or how common isolates are that are resistant found in advanced patients with advanced HIV disease, it's around 80%, which is close to 90%. Therefore, already you see that those who have advanced HIV disease are likely to be colonized and they are likely to have isolates that are resistant. The effects can be observed across all age groups and especially among those who have advanced HIV disease. One organism that I always think about, especially in our setting, is Streptococcus. This is very common as a cause of pneumonia. Most of us give antibiotics to treat for a pneumonia. You know, strep does cause pneumonias. It can cause meningitis. And you notice that despite introduction of vaccines, we still see changing epidemiology in terms of resistance to just the common penicillins and amoxicillins, which is around 20%, and we see that septrin resistance is around 30%. So already these organisms, most of the common organisms that we are isolating, are showing resistance, and the risks are much higher amongst patients with advanced HIV disease. And the risks of colonization is also much higher amongst these patients with advanced HIV disease. I hope I'm not scaring anyone. And most of us might be contributing to this epidemiology that we are seeing because we just prescribe antibiotics. Yes, it might be somebody who is exposed to animals. And all this could be impacting the noted epidemiology. So what are some of the common organisms that MDR in patients with advanced HIV disease? I think that across all different classes, it's very possible to get. I'll focus on the bacteria because these are the common ones that you're going to get. For example,
Dr. Chitalu, we've lost you again. Okay. So network, Dr. Chitalu will be back shortly. Network is an issue where is joining in us from just of note so far on what has been mentioned is that we have advanced HIV. Advanced HIV is actually higher in inpatients than outpatients. 50% of clients actually report with AHD, and this is an unverified data so far. And in Sierra Leone, it was mentioned that younger population were presenting with advanced HIV disease. When it comes to antimicrobial resistance, he has actually mentioned that 76 countries so far have reported antimicrobial resistance. And in one way or the other, we should be, as healthcare workers, among those who have contributed knowingly or unknowingly to the occurrence of this resistance. So far, that is what we have covered. As well, Dr. Monica Chibesankunda, your question has also been noted. It should be responded to. So network, kindly bear with us. Network is a little bit of a challenge from Dr. Chanda's side, and we are proceeding with the presentation in a minute. Dr. Chanda, are you on the call? Okay, just a minute, network, and we should be able to proceed with our presentation. Just a quick update for those who joined us a little bit late. Dr. Kozia was on the call. He briefly mentioned about the ECHO, which was supposed to be held last week on the future of HIV program in Zambia. So that wasn't done, and he has promised that as we move, an ECHO will be called, and we will be informed on how we are proceeding. So there are a good number of information coming in, and we should be good to go anytime soon from now. Dr. Chitalu, are you back on the call? Dr. Chitalu, are you back on the call? If you are talking, please kindly unmute. Okay, so network, just in a minute, Dr. Chitalu is trying to change the gadgets, and we should be good to go. Okay, for those who have joined us a little bit late, we are talking about antimicrobial resistance and advanced HIV. We have defined advanced HIV for all those who are less than 5 years, those who have CD4 count less than 200, and the WHO staging, stage 3 and stage 4. We have already defined antimicrobial resistance, where Dr. Chitalu has actually mentioned any pathogen. Okay, so be it a fungal, a parasite, a virus, or a bacteria which enter into a cell and protects itself from antibacterials or antimicrobials, and that is antimicrobial resistance. So from there, we move into the epidemiology, where he has clearly highlighted that some unreported data claim about 50% of clients who are experienced clients come with AHD, and it is more in the inpatient than outpatient. He has also highlighted that in Sierra Leone, we have younger population, having AHD than the other population. So now when it comes to antimicrobial resistance, he has actually mentioned that 76 countries have reported antimicrobial resistance, which is now a public health concern. He has as well highlighted that in one way or the other, we have somehow contributed to this resistance knowingly and most of the time unknowingly. Dr. Chitalu, I hope you are now back on the call. Okay, so Dr. Chitalu is not on the call. We have a signal that is changing another network. So please, network, bear with us. We should be able to proceed in the next 1 minute. Network, we still have challenges, and Dr. Chitalu is trying to join us. As mentioned, these are the common pathogens we actually have observed in advanced HIV disease. So we have on the bacterial, we have Staphylococcus aureus. We have the E. coli, Streptococcus pneumoniae, Pseudomonas Pseudomonas aeruginosa, Klebsiella pneumoniae, Enterococcus, and other mycobacterium. So these are the ones we actually see more frequent to be among causing actually drug resistance. So when we talk about the fungal, we are having more often the Cryptococcus and Candida. So on the viruses, of course, HIV is actually one of them. Hepatitis B virus has also come up very prominently. We have also herpes simplex virus. So these are the common pathogen which we see more often causing resistance in advanced HIV. As earlier mentioned, these conditions are mostly seen in the inpatients than outpatients. Okay. So now when we talk about the common drug resistance in advanced HIV, of course, when we talk about advanced HIV itself, CD4 count is actually a major issue because it helps us to account for the immunological function of the body. And when we have a defect in the CD4 count, we are likely to reach to a resistance. A high viral load is actually noted, and in a situation where you have high viral load, if that is not attended to, you find that in the process, CD4 counts also starts dropping. We have also noticed in practice that malignancies such as lymphoma, and of course, of late, we have a good number of lymphomas coming up, and the non-Hodgkin lymphoma is now becoming common. And you see that some resistance when this particular client is given antibiotics, you see that this is now generating into a resistance. Lack of vaccination, of course, this is at a good number of levels, be it in the peds and in adults, like the recent vaccination which we had. We have also noticed that a good number of clients were not vaccinated in the process. Adding to that, other comorbidities, they were having drug resistance. Colonization, Dr. Chitalu even talked about it. It is actually more common in the HIV client. It is actually seen most likely on, most of the time on the surface. Admission is actually one of them when you have these clients more often in facilities at the hospital being admitted, high chances of having some nosocomial infection. It is actually very likely. So prior antibiotic use, it is also related. So these are advanced HIV related, and we have as well the non-advanced HIV related, a situation where you have a immune system which is affected, like the case of diabetes, those who have a long time steroid use, plant treatment, this part of the traditional treatment, contact with animals, as well as smoking has been noticed as other factors to drug resistance in advanced HIV. Dr. Chitalu, are you back on the call? Okay. So we are going into the poll question number 2. IT, Kote, please kindly launch our poll question number 2. Poll question number 2, Kote. This is our poll question number 2, and good enough, network, you've started polling. So which one of the following is true regarding antimicrobial resistance? One health approach can be integrated. Vaccine is 100% effective in prevention of antimicrobial resistance. Antibiotic use does impact development of antimicrobial in those colonized Staphylococcus aureus. So please, network, we are very engaged. We are at 40% of the poll question, the answers received. We have 5 seconds to go and we'll end the poll. Okay, so we are ending the poll now. So network, this is how we've responded, and 61% believe that B is the correct answer, followed by 28%. Okay. So when we talk about organisms associated with advanced HIV syndrome, so we have a good number of them. We have meningitis, we have pneumonia, pyelonephritis, cellulitis, bacteremia, and enteritis, colitis. So these are the organism in the AHD syndrome. So now, let's talk a bit about the approach to management. Of course, when we talk about management, we have the prevention part of it, the diagnosis, and the medication, which is provided in regards to that. So now, when we tackle the issue of prevention of MDR infection in AHD, so the role of Septrin is actually key, and you will see the way it is highlighted in the advanced HIV guideline that Septrin, once given, it has actually shown benefits to a good number of opportunistic infection. So it reduced the incidence of bacteremia, reduced misuse and abuse of ceftriaxone, and risk of, it also reduced the risk of developing resistance. Of course, we have some studies here and there, and Dr. Chitalu even mentioned that we're having like 28% of resistance noticed with the use of septrin. But this is the advantage which it offers to us. So when we talk about vaccination, of course, that is actually recommended, and it actually reduced the prevalence of streptococcal pneumonia by approximately 84%. Infection prevention, water, sanitation, and hygiene, this is actually key. Of course, infection prevention cuts across, be it at patient level, facility level, as well as community level. So this is key, and we don't need to neglect about it. And other prophylaxis, like the case of TPT, that really help in having a reduction in microbial resistance. So when we move to the part of diagnosis of infection, genome sequencing is actually key. So diagnosis of infection, sorry, I was talking to myself. Yeah, so when we look at the diagnostic part, the diagnosis part of it, so we've talked about prevention. Now, when we look at the diagnosis of it, part of it, we have molecular tests, that is the sequencing. We have culture and sensitivity, and we have also rapid diagnostic test. That is the streptococcal antigen test and histopathology. And when we look at all these, they are actually done at a higher level, like the genome sequencing and histopathology. So these are the things we need to take note, especially when we are talking about diagnosis of infection from the prevention part of it. So when we talk about the treatment part, remember we are talking about three things here: prevention, we have talked about diagnosis, and now we are looking at the treatment, the principles of treatment. Of course, you cannot deal with antimicrobial resistance when there is no effective ART. So you need to give the appropriate dose, the appropriate regimen, and at the appropriate age. That is quite important. Effective ART is key. The role which we need to understand of presumptive antibiotics therapy, also consultation, because not everyone deal with antimicrobial resistance every day. Consulting senior colleagues is actually key, and ensuring that you have an effective treatment when you have this client in the ward. So this is the part of treatment. And as I mentioned on the effective therapy, so time, dosage, and the treatment given, its monitoring is actually key. So HIV treatment have to follow that guideline. So the time you provide your medication, the dosage, and ensuring that it's empirical, directed, and monitoring of that therapy. So this abide to the ART as well as the non-ART treatment. So that is what we mean by effective therapy when it comes to antimicrobial resistance. Okay, so we are actually landing, colleagues. What are we saying? What is our take-home message today? Of course, advanced HIV outcomes can be influenced by infection, and those are most likely multi-drug resistance. And prevention of antimicrobial resistance can be key to ensure that we have this in a combined manner, and that is going to help. As I mentioned earlier, when we talk about prevention, we are looking at the infection control. We are looking at the prophylaxis, which we give in our ART clients. We are looking at the antibiotics given when we are dealing with these clients while they are in the ward. Diagnosis and directed therapy can minimize antimicrobial resistance. So most of the time, medication which is given is more of syndromic than directed therapy. So when we deal with syndromic management, we are dealing with a war without knowing which enemy we are dealing with. So this combination of strategies actually will help us deal with antimicrobial resistance. So colleagues, I have seen questions in the chat. Okay, so we have, I can, okay, so we have some questions. Dr. Monica. Dr. Monica, you had asked a question. Do we have any data in Zambia showing that those younger than 35 years are more likely to present with AHD? Any reason for this? Okay, so I will give this question to the experts on the call. So before the expert comes in, there is Noah Ndolovu. Okay, so this was a comment. Okay, so Noah, we apologize. Our network has been quite poor, but everyone has got the gadget. Okay, so the second question is in regard to admissions contributing to hospital-acquired infection in inpatient with a lowered immunity. Is anything being done with the infection prevention to prevent some of the acquired infection on both patients and healthcare workers? Okay, can you explain the use of plants as risk factor? Okay, so these are the questions. Dr. Matibula, are you on the call so that you can pick these two questions which have been asked? Dr. Peter Matibula? Dr. Kapolowe?
Moderator, this is Dr. Kanika. Can you, I'm the clinical coordinator. What was the question again?
Oh, thank you, Doc, and welcome on the call. Okay, so the first question was in regard of the data which we have as a country in regard of those showing, I mean, the younger age who are likely to have advanced HIV. Do we have any data in Zambia showing the young age and what could be the reason for it? And the second question goes to acquired infections. So what can we do to prevent hospital-acquired infection, both on the patient side as well as on the healthcare worker side?
Okay, thank you. So I'm going to keep the first question because I haven't done any studies on that subject, and I haven't worked with anyone on that subject. But for the second one, in terms of prevention of acquired infections, so when you look at acquired infections, there are two things that you can do, both for the patients and for the healthcare worker. So in terms of you as the healthcare worker, the number one thing is to make sure that you observe hand hygiene. Now, with hand hygiene, it's not just about using hand sanitizer and using gloves. There's also the washing of hands. For example, there are certain common hospital-acquired infections like Clostridium difficile that will not get disinfected even after you wash, even after you use hand sanitizer. So then the other thing that you've seen, if you've noticed, especially from our side as health personnel, there is a bigger push now towards using lab coats that are short-lived, because actually it's been proven quite a lot that with our labs, especially when they are long-lived, they do tend to carry a lot of infections. Yeah, so those are some of the things. And then especially with you again as a healthcare worker in terms of hospital-acquired infections, it's also observing there are certain rules of hygiene, for instance, where you can carry infection actually from one person to another. So it's advisable, especially for those with weak immunities, that before we handle them, we make sure that we wash our hands before we move on to the next person, whether we are nurses, whether we are doctors, and the like. Now, for patients, it depends on what sort of lowered immunity they have. So the most extreme cases, depending on what health facility you are, is of course isolation that can be done for the patients. Sorry, I think someone needs to mute their mic. On the patient side, there's isolation, of course, that can be done. And aside from isolation, again, it depends on how lowered the immunity. For instance, we may have situations like, let's say, if someone has a very, very low white cell count, we do sometimes institute what is known as their SIP bundle, where we keep them isolated in a room, and then we make sure that we prophylactically put them on antibiotics. And then there are certain instances, sometimes even when we advise these patients not to use tissue, they should use water. So it depends on how depressed the immunity is. Now, coming closer to our context here, because we're talking about HIV disease. So for patients, of course, with advanced HIV disease, where we expect the CD4 to be low, we shouldn't forget things that have been placed at our disposal, like the advanced HIV disease bundle, which I think was talked about in the presentation. So these are just basics. I'm sure that all of us on the call are aware of, to say when there's a CD4 this low, we need to make sure that patient is on Septrin, our patient is on TPD have not been instituted, and our patient is on cryptoprophylaxis. I hope that input has helped in adding some clarity to the question I submit. If any of the panel of experts are on the call, then it would be good to hear their comments as well.
Thank you very much. Thank you very
Dr.
much,
Mongomba.
Dr. Chitalu. Yes, please.
This is Dr. Mongomba, if I'm allowed to chip in.
Yes, Dr. Mongomba, please kindly go ahead.
I just thought of contributing because the presenter couldn't join and finish. maybe on the next session, we'll probably ask him to come back and summarize his presentation. But in addition to what Dr. Chitanika mentioned, infection prevention is very key to actually, reduce the risk of hospital acquired infection. And this is the reason why all the procedures that we conduct in the clinical setup should actually be adhered to. One of the most common hospital-acquired infection, we have it as UTI due to Klebsiella. Community-acquired UTI would probably present with E. coli, but hospital-acquired UTIs will present either with Klebsiella or sometimes even the staph can be found. And you will see that the urine will carry some pus and some deposit in when you look at the urine bag. And usually this happens when you have your patient catheterized. So some of these infection prevention measures that we need to adhere to, especially for UTI, as simple as the procedure that you do when you are inserting the catheter. You need to strictly adhere to that. You have your gloves, you clean the private part of the patient or the genitalia before inserting. And when you have your catheter in place, you keep it for so many days and quickly remove it. Because when the catheter overstays, definitely you have infection that starts developing, and making sure that your catheter is clear and its urine is flowing freely, because when the urine also overstays in the bladder and is not flowing freely, you have bacteria that start developing. So this is just one component of how we can present this hospital-acquired infection. This can be applied to even things like, catheter cannula that we use. When you put a cannula in place, for how long are you supposed to keep it, and when should you remove it? You need to cover it so that infection doesn't go through. When you are coming to inject drugs using that cannula, you look around the cannula, is the cannula looking clean and everything? And ideally, when you move from one client to another, you need to wash your hand before you start attending to the next client. And these are some of the things that we usually overlook and we don't always put into practice. But just by following strict IPC procedures, we should be able to reduce occurrence of hospital-acquired infection. Then let me comment on the advanced HIV disease prevalence in Zambia. Indeed, we do not have published data around that. And, data will vary from one setup to another, from one hospital, one province to another. We were sometimes we're sitting at around 17%, but some data will tell you we are at high as 40%. So we do have quite a lot of AHD, but there is need for us to really have robust systems in place where we collect this data and kind of publish it. So we don't have published data around that currently. I think those are the few things that I thought of mentioning. And there's a question also from asking, can those clients who develop heart failure or kidney failure classify to have AHD? I think definition of AHD, we know what it implies. You can use CD4 below 200, or you can use the WHO clinical stage 3 or stage 4 condition. And I do not think heart failure falls into any of those categories. Kidney failure also does not necessarily fall into that category, but we have condition that the Ivan syndrome, HIV-associated glomerulonephritis or nephropathy. You can have HIV that is caused a nephropathy. Probably on the long run, this can lead to kidney failure, but there is no direct link between kidney failure and advanced HIV disease. Then question on DM and antimicrobial resistance. I'm sure for those who have been working in clinical setup, you will notice that clients that have uncontrolled diabetes tend to develop a lot of infection, especially with pus-forming bacteria. They will come with abscesses. They will develop peripheral vasculopathy and ending up with sometimes gangrene and amputation. This is somehow because you have the blood of someone with high glucose represents a very good media for bacterial proliferation. And as these bacteria proliferate, you have to use stronger and stronger antibiotic. And if you are not guided by culture and sensitivity, you will definitely end up with antimicrobial resistance by changing randomly your antibiotics here and there. This is just one component of this, but there's quite a lot that can be said around this. I just thought of bringing in a few clarity since we have a good number of panelists not on the call. Thank you.
Thank you very much, Dr. Mwamba, for this insightful feedback on the other two questions which were asked. Dr. Chitamika and Dr. Daniel Mwamba, may you please comment on the issue of plant administration of plant medicine as well as antimicrobial resistance in advanced HIV. This question has been asked. If you may as well, I speak more to it.
Dr. Chitanika, do you want to go
go ahead? No, please go ahead.
So I am not sure to understand exactly what is being referred to when we talk about plant medication, but Dr. Chitanika, you can come in after me. I have two opinions over this. Are we referring to plant same as the way we've been having a number of antibiotic use in the farming aspect? So if that's the case, then I know antimicrobial resistance also is quite prevalent in the animal setup, because these animals are bombarded with a lot of antibiotics to prevent, but also to treat various infections that are seen. And you have quite a lot of cases of antimicrobial resistance that generate from there. But when it comes to the plants, I'm not that sure. I thought, okay, the way I understood it, I thought this was transplant. Client to receive, transplant or organ transplant, I usually put on not only steroid, but chronic medication that lower the immune system or immunity, which put them at risk of developing a number of infections. And then because they will develop infection, you have to put them on antibiotics constantly. And this might lead to development of microbial resistance. So that's how I understood that. I wasn't really part of the slide development on this one. I might be wrong. So Dr. Chitanika, you can come in. Thank you.
Thank you, Dr.
Thank you.
Daniel. Dr. Chitamika, please, your comments.
No, I was going to say exactly the same thing as him. I'm not sure in what context the use of plants was mentioned, because having plants inside the hospital, because if you have plants inside the hospital, they have those flower pots, and then they'll have dust, and they release different fungi and bacteria. So it's difficult for me to comment on that one. Yeah, that would be my submission.
Thank you very much, Dr. Chitamika and Dr. Daniel.
Dr. Mongomba, sorry, is Dr. Kapolowe here? Sorry, I dropped off for some time.
Okay, Dr. Kapolowe, please. You are welcome. Kindly go ahead.
Thank you very much. So quite an insightful topic. And of course, unfortunately, the presenter couldn't complete the discussion. However, I think we've learned quite a bit. I thought of just contributing by probably summing up what was the gist of the presentation this afternoon. So very good presentation, and I'm happy Dr. Mwamba, Dr. Stanika, I think touched in on infection prevention when it comes to AMR. So here we are looking at two things. We're looking at advanced HIV disease and antimicrobial resistance. Quite a lethal combination, as you can be aware. So now there's a lot of talk of antimicrobial resistance. I think, like Dr. Chitalu had rightly mentioned, I think in the introduction, we've made a lot of strides towards epidemic control. However, mortality still remains quite significant amongst our clients with advanced HIV disease. So now, how does antimicrobial resistance come in this picture? Okay, so antimicrobial resistance has a potential to actually reverse all the gains that we've done when it comes to the progress that we've done when it comes to epidemic control. So our clients with HIV are affected, AMR affects them in two ways. So like it was mentioned, and microbial resistance basically means resistance to microorganisms, to basically all the antimicrobials. Could be fungal, could be viral, could be bacterial. So our HIV clients are affected in two ways. Of course, the HIV itself, the virus can develop resistance towards the medication that we give them. And that's something that we are particularly well vested in. We've been talking about drug resistance, first line, second line, isn't it? Yeah, then of course, if that's not taken care of, patients that have drug-resistant HIV can pass it on to other people. Then we have a lot of drug-resistant HIV in the population, which might be very difficult to treat. But also here, when we talk about antimicrobial resistance, it's more synonymous to antibiotics. Okay, so I guess this presentation was more inclined to the antibiotics. Okay, so meaning that our clients living with HIV are also particularly vulnerable when it comes to bacterial antimicrobial resistance. Okay, so they carry a significant risk of serious bacterial infections, pneumonias, or meningitis, okay, which can actually contribute to the higher mortality in these patients. And of course, these patients also with advanced HIV disease will tend to have frequent hospital visits. And with the hospital visits, they are at a high risk of picking up other infections, other bacterial infections, because the immune systems are weaker than other patients. So here, really what we need to focus on is more on how do we tackle the issue of antimicrobial resistance and advanced HIV disease. So I think the simple principles, and that I like what I think a colleague had mentioned earlier. Infection prevention is one of the key interventions when it comes to the fight against antimicrobial resistance. Okay, because when we have these patients admitted, we want to make sure we do IPC principles to prevent these clients from getting resistant infections. Okay, so simple hand washing, for instance, making sure we wash our hands before we touch the next patient, our stethoscopes, just simple principles of hand IPC can help reduce antimicrobial resistance in these patients. Then, of course, we need to be on the lookout for this serious bacterial infection, meaning that we need to diagnose them early. And ideally, we need to make sure that we have microbiological diagnosis. For instance, if this patient comes in with a pneumonia, we need to do cultures, sputum cultures. If it's a bloodstream infection, for instance, we need to do blood cultures, okay, so that we know what sort of organisms are causing the infection. Then we give the right antibiotic, because the major driver of antimicrobial resistance is actually the overuse of this antimicrobial that we use. Yep. So it's a whole lot of topic when it comes to AMR, but I think simple principles will help our clients with advanced HIV disease in terms of preventing them from having antimicrobial resistance, particularly to antibiotics. Yeah, so I thought I could contribute on that end. Thank you.
Thank you very much, Dr. Kapolowe. This is really a summary, so I do not need to, again, go back to the summary. Network, unless if there is a question, please kindly unmute and ask your question to the panel of experts. Okay, so if there is no question, your last comment, Dr. Chitamika, in a minute, vis-a-vis to antimicrobial resistance and advanced HIV, what is your last comment?
Thank you, moderator. So I think, as earlier alluded to, I think I'll just echo Dr. Kapolowe's words in saying that despite the gains that we've made, we are still seeing a huge amount of mortality on the ground. So this is something that we will need to pay attention to and to take special precaution, especially looking at the pathogens that were looked at today, Enterococcus, Klebsiella. Know that we are aware about antimicrobial resistance and which antibiotics we can run to, and also not forgetting some very, very important things that Dr. Mwamba touched on. Before we run to blindly prescribing antibiotics, let's try as much as possible to engage our labs at our various stations. If we don't have a lab, maybe the next available center, so that we can do basic cultures, even of urine, even of stool, even of blood, just so that we are able to know exactly which pathogens we are facing and able to tailor our therapy to them. Those would be my last remarks.
Okay. Thank you very much. Dr. Daniel, as you are giving your last remark, can you kindly comment on how this question which was asked by Banda, how do we prevent antimicrobial resistance from a public health perspective, seeing that some of the patients just go to pharmacies and collect some medicine from there without being prescribed? In a minute, Dr. Daniel, your comment?
Dr. Mongomba, can you hear me?
Yes, I can
Am
hear
I
you.
audible?
Yes, you are.
Yes, this requires quite a lot of work in terms of education and sensitizing the public. Things like self-prescription, over-the-counter medication should also be addressed and discouraged, but also to educate both the providers as well as the patient. It's very common to see when a client goes into a clinic and they are not prescribed an antibiotic, they come out and say, I wasn't given anything. Because when you just give them paracetamol for them, they feel like this is not medication. So that is a culture that we need to fight. And we know that in most of our private clinics here, there is overprescription of antibiotics, because the more you prescribe, the more money you make. But so those habits should be really change, but that requires a lot of sensitization and as well as education. But then the other aspect is we should our prescription should be guided by evidence. Do we have culture? Do we have culture result, sensitivity, and everything? And once we prescribe, we need to make sure that the combination of the different antibiotics that we make actually speaking to the isolated germs. So that is on a clinical side, both from client and as well as providers, but at much higher level as public health approach. Do we have the lab capable of running all these tests so that can guide the one who is prescribing? Remember, this antimicrobial we are talking about, it goes beyond bacterial infection. We've seen it even in malaria. How many times have we prescribed Coartem when we actually have a negative blood slide? So those are the things that we need to address. But actually, some of these issues can be addressed through the ECHO platform, as we are having one like this, discussing prescribing habits, but also educating our healthcare providers as well as clients. Since I only have 1 minute, I think I will stop here. Thank you.
Thank you very much, Dr. Daniel. Quite concise response. Network, we've come to the end. Mongomba and Sokesi, your questions have been noted. Network, you'll bear with us. Our today's ECHO, we had a lot of challenges when it comes to network, but we do appreciate your efforts and the expertise from Dr. Daniel Mwamba, Dr. Chitanika, and Dr. Kapolowe coming in to ensure that questions asked are responded to with fidelity. Once more, we are very thankful. Colleagues, network, we are ending here. Please kindly join the Thursday ECHO, where we'll be talking on the clinical, radiological diagnosis of tuberculosis, bridging clinical insights with imaging techniques. So this is the topic we'll discuss on Thursday. And once again, the antimicrobial resistance topic has not ended here. As you have heard, we need to talk about it more and more again. So we shall plan for it again, where we'll have some of these questions we have seen in the chat responded to. So at your convenient time, Mongomba, Sokesi, you can still connect us or connect with us so that we have some of these questions responded to. Once more, thank you, network, for your time. We are signing off now. Thank you. Bye-bye.